So welcome to this Nocturnal video fitting guide. In this video we're going to cover assessment of the patient. I'm Scott Brown, optometrist at Scotlens. So in previous videos we've covered the refraction correction. In this video we're going to talk about assessment and topography assessment in order to get all the information you need to order your lenses. Now for more information on topography specifically, we have a video series called Topography Tips that takes you through various components of topography, so you can feel free to check that out. Now, our baseline topography is really key in ordering the lenses, both from the point of view of we use the three-dimensional model to design the lenses, or we use information from topography to do it, but also the baseline is unlikely to change with patients unless there's some degree of ectasia there. You can see on this patient that 14 years apart, there's no change between the patient's cornea. So cornea, the baseline topography is inherently stable, and we can refer back to it if we need to without needing to do any washout. In order to get a good baseline, we want to make sure we've discontinued any contact lens wear. So with soft lens wearers, try and minimize or discontinue lens wear for 2 weeks if you can. Certainly no lens wear on the day of topography capture, and you want to get 3 maps for each eye for the patient. Avoid doing any software integration or software compiling. You can see in this example, we've got 2 maps that appear to be quite good, but actually we've got an issue with the height and the composite map function that we didn't have with the individual map. So it can be hard to work out where the errors come from, so just stick to individual captures. When we've got our topography, we've screened out at this point any abnormalities, any ectasia, and we're now dealing with normal corneas, and we're going to assess these normal corneas with the axial map in a normalized scale. The left-hand side map, this map is a spherical map. So we'd expect this, if we look at the post-wear analysis, you can see that the map on the right, we've done a comparison or subtractive map. So this shows us the refractive change that the lens has caused. The map on the left, we've got spherical. We started with a spherical cornea, nice and symmetrical. So we'd expect the treatment zone as it is to be nice and central on the pupil. If we've got, again, this is a fairly spherical cornea, but we've got a decentered corneal apex, we'd probably expect the treatment zone to move towards where the corneal apex is. Small amounts of decentration won't cause any issues for the patients. With higher prescriptions, of course, decentration will exaggerate any effects of a high prescription. You don't need to exclude patients from fitting, but you need to be aware that the treatment zone will move slightly to where the corneal apex is. Looking at these 2 central maps, and we've got similar degrees of astigmatism with these maps. The left-hand side astigmatism is central astigmatism, and this is the type of astigmatism that tends to correct better with ortho-K. So we tend to see a fuller correction of the astigmatic prescription component. Whereas limbus to limbus is where you tend to get less correction, and you're going to end up with a residual cell. Sometimes with ptericity, we can see a bit of decentration, typically either low or high, tend to be vertical. The map on the right-hand side, this is where we've got asymmetrical astigmatism. Again, we've got high corneal apex in this case, so we would expect the treatment zone to be moved towards that. The other thing that's really useful from topography is to look at how decentered the patient looks through their cornea. So in this example, you can see the purple line around the limbus is marking the periphery of the cornea, and the purple cross in the middle is marking the center of the cornea. Now, the patient who's looking at the middle of the Placido-Myers is not looking through the center of the cornea. It can be measured with the ruler function on your topographer, and if you measure this to be 0.8 millimeters or more, then the chances are greater than 0.8 millimeters is going to lead to disruption in the vision. Again, higher prescriptions, we need to be more sensitive to this measurement, as patients will get a poorer outcome the higher this measurement. So we need our patients to be generally suitable for contact lens wear. They need to be able to follow the good practice, keeping the hygiene clean. They need to not have any active infection or disease of the eye. They need to not have any severe dry eye or corneal hypersensitivity. Contact lens discomfort due to dryness is fine, and patients will actually benefit from not having a contact lens in during the day, so that can be a plus. And obviously they need to not have any non-reaction to contact lens or lens solutions. So once we've established that we've got a suitable patient, we're then going to provide them with written information. So you can provide them with the Nocturnal brochure that's going to outline what the lenses do, what they're likely to experience, and then you can order your lenses. So for more information on nocturnal fitting, continue watching the series, or for other information, email lab@scotlens.com, and thanks for watching.